Mr. the Chairman, member of the audience, I would like to thank the organizer for giving me the privilege of the podium. So I will discuss about the new frontiers in SAVR. How do I change the slide? So I have no financial disclosure. My only disclosure is that I'm a surgeon fully trained in SAVR and TAVR, and that may influence my thinking process while discussing the approach. So in the current era, I will not come back to this concept because Dr. Asgar, I think, explained it well. So there is no one-size-fits-all model. We have now access to new technologies. And usually what we do to decide about the approach is to discuss and to calculate the risk score according to the standard risk score that we use. So that include patient age, sex, redo surgery, renal failure, etc. But we need to take into consideration that there's other factors that are not included in common risk scores. And those include anatomical factor, frailty, radiation, orthopedic issue that limit rehabilitation, pulmonary hypertension, etc. We need to take into consideration as well patients' preference, level of activity, and quality of life, as well as their anticipated life expectancy. So I will go over all the possible approach for aortic valve replacement, starting with the tissue valve. So the Achilles heel of the tissue valve is really the structural valve deterioration. And it's very true for people that are less than 60 years old. So if you look at the graph on your left side, so you can see that for people who are more than 70 years old, the rate of degeneration is almost none. So they should be good with that valve for the rest of their life. For 60 to 70 years old, it's the gray zone. So basically, those valves start to degenerate around 10 to 15 years. And for less than 60, we can see early degeneration as soon as 8 years following the implant. In terms of the survival, this is a cohort of patients that were less than 60 years old, and they were age and gender matched to a Quebec population. And you can see that their survival decreased dramatically once they got their tissue valve implant. When you look at the OD ratio by age group, so for the people less than 50, the OD ratio for death is 4.5, 51 to 60 is 2.7, and it decreased to 1 to 2% when you get over 60 years old. So for conventional AVR in the young, there's definitely excess mortality. For the aortic mechanical valve, so we know that they last longer. However, you have the trade-off of the 1 to 2% per year of cumulative risk of minor or major bleeding. In terms of freedom from reoperation, we can see here that the survival free from reop is 82% at 10 years. And if you look at the same survival curve, but for patients with isolated mechanical AVR, you can see that still, compared to age and gender matched Quebec population, it decreased considerably. So basically, it means that at 10 years, 1 in 5 patients is dead or reoperated. But however, there's several advantages of using those valves. So low mortality, surgical mortality, it's a standardized approach, is easily reproducible, short operative times, and long-term data. We have access to other technology in terms of the mechanical valves, such as the Onyx valve. So the PROAC results have shown that it decreased the rate of bleeding of 65% by targeting an INR of 1.5 to 2. And it reduced the rate of major and minor bleeding. So here it's 2.74% per patient year versus 7.85. However, the rate of major event that include major bleeding, all thromboembolism and thrombosis is not different, meaning that it's not inferior. What I call the natural approach, so we have access to the Ross procedure. So basically, it's replacing the aortic root by the pulmonary valve and putting a cadaveric homograph in the pulmonary position. So this is the only replacement operation that guarantees long-term viability of the aortic valve root because it's a living structure. However, there's negative biases associated with that. So it transforms a single valve disease into a double valve disease. It has high operative mortality and morbidity, and high rate of reoperation. In terms of the survival, this is a systematic review done on 5,000 patients, and the late mortality rates are low and resemble the adult series age-matched population mortality. And Dr. Lamamsi did a study on that, comparing the ROS versus a nomograph in the aortic position. And we can see here that the ROS compared to a general population have the same survival. So in terms of survival free from reoperation, the ROS is similar to the mechanical valve and significantly different in versus the tissue valve. For the ROS reoperation, so basically the aortic, so basically the pulmonary autograft degenerate first, and so that's the problem with that. But it has a percentage of any reoperation at 15 years of 85% of freedom from. So basically the ROS procedure is the only replacement operation that restores long-term survival following aortic valve replacement. In terms of valve repair, we use it mainly for aortic insufficiency. So you can primarily repair the valve or proceed to a valve-sparing route if it is associated with aortic root aneurysm. But you need to take into consideration some factors. So patient survival, estimated survival, the valve-related complication, the quality of life of the patient, and echo and intraoperative determination. Because the feasibility doesn't always mean the durability, so you need to use your judgment. So basically on the left side, you can see a valve sparing for the one who are not familiar with that. So there's two techniques. So the reimplantation that we call David, or the remodeling associated with Yakub. So for the letter B, it's a David. So basically we resect the cusp and we reimplant the valve inside a Dacron tube. Versus the remodeling where we scallop the neosinuses in the Dacron and we saw around that. So there's, so basically for the reimplantation technique, it treats the annular dilatation, it stabilizes the AV junction and the ST junction, but it doesn't restore the sinuses of Valsalva. For the remodeling, it doesn't treat annular dilatation, doesn't stabilize the AV junction, but it stabilizes the ST junction and restore the sinuses. So what is done right now is just the combination of the remodeling and annuloplasty. But majority of the case will do a reimplantation, but if you decide to do Yakub, you better do annuloplasty just to make sure that you stabilize your annulus. So basically, this is the basal ring, and just to stabilize the annulus with the extra aortic annuloplasty, we just put plegited with the Dacron circle that we put around it. We create an annuloplasty. In terms of survival, for all the repair versus a conventional AVR, we see overall better survival for patients who underwent a repair. And this is an experienced group, once again, so for the valve sparing. They did reimplantation in majority, so, and 12% of their patients had acute type A dissection, 35% had Marfan, and still the survival at 20 years is really good, like over like 75%. But it's a little bit lower than a match general population. In terms of AV repair durability, so this is an experienced group, once again, that have been doing this since 1995, and when they compared their time period, they have better results in the later one. So the improving results with experience and understanding. In terms of quality of life after aortic valve repair, so basically it's similar to the ROS patient. So for repair, similar to the ROS, but superior to mechanical valve. And what was driving this was the long-term anticoagulation that were related to worse quality of life. In terms of newer technologies, we have access also to sutureless valve. So basically, it results in a reduction in cardiopulmonary bypass time and cross-count time, but which could result in less morbidities and mortality, but this has just been proven in patients with low left ventricular ejection fraction. You can have better hemodynamics outcome, it facilitates the minimally invasive surgery, and you can deploy under direct vision. This is the Canadian multi-center study for the sutureless valve. So it includes 215 consecutive patients from 6 centers. They used the Percival S bioprosthesis. The mean age was 79 years old, and 54% were women. And they used concomitant procedure in 40% of them. Their operative mortality was 4%. There was no valve migration or embolization. And however, they had 17% rate of permanent pacemaker implantation. In terms of hemodynamic data, it was excellent. We also have access to newer technologies such as the TAVR that are commonly used in the high and intermediate risk patient, and now there's ongoing trial in the low risk patient. I'm not going to discuss that because I know that Dr. Généreux will do it. But just to show you a little bit, so this is from the TVT and STS registry. So with the years, the volume of TAVR that were implanted in the States increased dramatically. In 2017, now they are at 32,000 implants. But you can see on the red line that the volume of SAVR didn't decrease in proportion to the increase in volume of TAVR. So this is the result of partner 2A in the intermediate risk patient. So you can see that there's an equipoise at 2 years in terms of all-cause mortality, disabling stroke, and this is from the SURTAVI trial with the core valve. No difference in terms of all-cause mortality and disabling stroke as well. We recently did a deep dive analysis of especially the SAVR patient in this trial. So basically all intermediate risk patient, 937 patient, because we wanted to know exactly what was going on with those patients and how we could explain the outcomes. So we evaluate the early and 2 years outcome of the 937 intermediate risk patient from that cohort. So mean age was 82 years old, 45% were female, and 10% had a prior stroke, 12 prior pacemaker, and 35% prior atrial fibrillation. In terms of mortality by surgical procedure, up to 2 years, there was no significant difference in between all the groups. In terms of mortality by incision type, so less invasive versus full sternotomy, there was no difference in between groups. In terms of mortality by severity of patient prosthesis mismatch, there was no difference at 2 years. No difference in terms of stroke by surgical procedure. No difference in stroke by mini versus full sternotomy. So basically, the risk factors for death after SAVR at 2 years were lower baseline BMI, higher baseline tricuspid regurg grade, presence of CAD, pre-op atrial fibrillation, higher baseline white blood cell count, and lower baseline hemoglobin. And the risk factor for postoperative stroke after SAVR at 2 years were older age, lower baseline ejection fraction, and longer anesthesia time. So the conclusion of this study is that operative mortality in SAVR patient in the partner 2A was 4.4%, somewhat lower than the STS expected rate of mortality. The time-related event demonstrate a period of higher early mortality, followed by a more constant risk to 2 years. In-hospital stroke was 5.4% for all patients and twice what was expected, but this is most likely because those results were adjudicated, and so basically all the patients had formal neurologic assessment. Minimally invasive AVR does not result in increased mortality or stroke compared to full sternotomy for patients with isolated AVR. But the thing is, why I'm presenting this thing is that 33% of patients had severe patient prosthesis mismatch, but had similar survival to those without severe PPM, but those results were at 2 years. We saw some regression of LV mass also at 2 years in those patients. Echocardiographic data showed an improvement in mean gradient ejection fraction and aortic valve area compared to baseline. So this is my algorithm, but we can discuss about it. So basically for patients that are less than 60 years old, so a patient that comes to you that are really good shape, no significant comorbidities, doesn't want to know anything about anticoagulation, and doesn't mind about having another surgery in the future, and is pretty active, I think that it's reasonable to offer ROS or, depending on the etiology of the disease, an aortic repair. If we were to offer them a tissue valve, it's because we think about the option in the future, such as TAVR, for example, but we need to be ready to do a root enlargement. First, to be able to put a TAVR inside, so you need to put a 23 at least, and also because of the PPM that I just discussed about in the previous study. And if the patient doesn't mind about taking Coumadin and doesn't want any other operation in the future, we can offer the mechanical valve For the patient in the gray zone, the 60 to 70, I think it's reasonable to do a biological tissue valve with root enlargement if necessary, or a TAVR if he has any other risk factor, include or not include in common risk score. For the patient more than 70, TAVR versus a tissue valve. So in conclusion, we need to offer what is best for the patient after assessing him as a whole, and it's not one-fits-all approach. We need to consider the present and the future challenges related to each therapeutical option, considering the patient preference. We need to change our surgical mentality, and it can be Ross or just tissue valve or anything, just to be ready to do root enlargement and more extensive procedure at the beginning. We need to be honest with the patient and cognizant of the literature. So basically, we need to know the data, and we need to tell the patient, for example, if it's a Ross, that he may require another surgery in the future, and he will take the decision, or if it's a tissue valve, that we can possibly put a TAVR in the future, or he will need a reoperation. Technology iterations are rapidly expanding to allow novel therapy to become the mainstay in valvular therapy. The dialogue between cardiac surgery and cardiology is of utmost importance in the decisional algorithm, and this results in a functional art team. And I don't think that we should just discuss high risk or inoperable patient, but all patients with a valvular disease. And cardiac surgery is evolving, and novel therapies should now be part of our armamentarium. Thank you for your attention.